Thank you so much, everybody, for being here. My name is Paul Ford. I'm the Mobile Integrated Healthcare Coordinator for the Las Cruces Fire Department. So we're gonna talk about what that means and why the fire department is doing things other than fighting fires. And we're going to talk about what I see that's going on out there in the community. So I thank you, everybody, for being here today. So the Las Cruces Fire Department has 180 sworn personnel. We have 8 advanced life support fire engines. We have, come on in, guys. We have 4 reserve fire engines. We have 2 ladder trucks. That's the truck with the big ladder on it. We have 3 squad ambulances that we can use to take patients to the hospital. We have hazmat, we have technical rescue, we have all these different types of programs, and we have mobile integrated healthcare. So what is mobile integrated healthcare? Well, we will talk about it. So the fire department has been around for centuries. Fire safety concerns led to the development of the National Fire Protection Agency in 1896. And we created a whole bunch of standards for fire codes and standards to make buildings more fire safe. And that includes this building. When it's built, we make sure that it has a sprinkler system in the ceiling, that it has smoke detectors, that it has panic hardware so you can exit in the event of an emergency, and all those types of things. So buildings have become more safe and fires have become more relatively stable over the past 30 years, but the fire department call volume continues to grow. Well, why is that? Well, if you take a look at this graph from the National Fire Protection Agency that I pulled off on 2020, it shows that fires since 1980 have actually gone down, but the amount of medical calls that the fire department goes on has steadily increased, and we are now above 25 million 911 calls that are medical in nature that the fire department in the United States goes on every single year. Why is this? Well, it's because we're meeting a gap that individuals are utilizing to seek access to services, and I'll explain why that is. So this is actually mirrored by our own data. The fire department's 911 call volume increases by 3 to 4% every single year. And if you look, we only go on 226 fires, which is only 1.15% of all 19,000 calls that we went on in 2019. And those fires are everything from a trash can in the corner of an office to a raging, burning building. It's only 226 fires in 2019. But look at all the calls that we go on for medical, 17,522 medical calls. That's almost 90% of our call volume. And then if you look underneath that, we have lift assists, which is when we go to pick up somebody off of the ground, but they're not injured. There's falls when we go to pick somebody off the ground and provide treatment, but they are injured. And then there's public assist. And public assist can be anything from an elderly lady calling for us to fix her thermostat, adjust her thermostat, retrieve the remote, I smell gas in my garage, any number of things, and we fill that niche as well. And when you take all 3 of those, that comprises 1/5 of our call volume. So that kind of, we were looking at those types of things and determined that we needed to do something differently. But there are half as many fires as there were 15 years ago, but 50% more people paid to fight them. And that makes the public really upset because they pay taxes and we don't have a lot of fires. Why do we have so many firefighters? Why are we building so many fire stations? Well, that's because that's not what we do. I mean, we fight fires. We have the knowledge, skills, and ability to do it, and nobody else is going to do it. And so, we train very hard and we mitigate those situations when they happen, but that's not what we do. What we actually do is we do emergency medical care. We have hands on tens of thousands of patients every year in the Las Cruces Fire Department, which makes us one of the largest providers of healthcare in southern New Mexico, but the fire department is not traditionally viewed as a healthcare stakeholder or a healthcare provider. So we understand that 911 is becoming the standard for at-risk populations to access healthcare. When they call 911, they know that within 4 minutes they're going to get 4 competent individuals, including a paramedic, that will do a workup on them. An ambulance will show up that they don't have to pay for up front, that will give them a ride to a hospital so they can see a physician, so they can get a prescription. And if they don't have a ride back, the hospital will give them a taxi cab voucher with which to go back home. How do you combat that level of care? By telling somebody that you want them to access health care and go to their primary care provider, go to the pharmacy and pick up their prescriptions, go to physical therapy, and do all of those types of things when this is so easy and so accessible to the public. So in identifying that problem, much like the transition in the 80s and 90s when the fire department started taking over emergency medical care because we had all these fire stations dotted everywhere and we could get to somebody really quickly, we're now looking at emerging into some other community-based wellness services, and that's called mobile integrated healthcare. So MIH is an overarching phrase that involves, it's an umbrella of many different pre-hospital community-based wellness services that the fire department or the 911 system as a whole does. And some of these you're going to be familiar with. So there's community paramedicine, which is in-home readmission, hospital readmission prevention using point-of-care testing and equipment. And this is common for congestive heart failure patients because congestive heart failure patients often go back to the hospital within 30 days, and most, if not all of them, are on Medicare or Medicaid, and CMS is not going to pay for that readmission if it's within 30 days. So many hospitals across the nation have actually worked with fire departments for them to go in and visit with that person and provide some point-of-care testing, weigh those patients, and provide medication for them. And that's keeping patients out of the hospital. There's also 911 nurse triage, where instead of calling 911 and a dispatcher having a minute to make a decision as to what it is that they're going to send, and they end up sending the police and 4 firemen and an ambulance and all this stuff, they can instead transfer to a nurse or a behavioral health provider that can provide consult and navigation for them over the phone to potentially come up with a resolution for their situation. And then there's mobile behavioral health care, which is a really hot topic right now. I'm sure you all are familiar with mobile crisis, where you create in the 911 system a tailored response model that has a social worker and some sort of a behavioral health provider and a paramedic that goes out and responds to those 911 calls. And then there's where most fire departments start, which is care coordination, resource navigation, and social services. And that's currently what the fire department does, and we're going to talk about it right here. So we have 2 tiers of this program in the Las Cruces Fire Department under MIH. And the first is our Vecino program. We have a lot of people that call 911 frequently. They are at-risk seniors and they're disabled and they're in and out of the hospital, and they really require that tailored approach and that personal touch to do some intensive case management for those individuals to facilitate good outcomes. And then we have the OOO program. That's our opioid overdose outreach program, where we go out into the field and we respond. We look at all the overdoses that happen in the 911 system in Las Cruces, and then we go to the area where that overdose took place, and we engage with that individual, and we offer them Narcan, medication-assisted treatment. Do they want to ride somewhere? Do they want this? Do they want that? And then the third leg of the stool is something that we're looking at doing in the future, and that's mobile crisis. So in the 911 system, we would like to create a tailored response through the fire department with a paramedic and some sort of a behavioral health provider to respond to those instead of sending the police department in an ambulance, so we can meet those individuals where they're at and we can transport them to definitive care or come up with some other solution for their situation. So the Vecino program is intensive case management, like I said before, and we're bringing health and human resources to the public in their home, and we focus on underserved populations who utilize 911 to obtain services that can be obtained without using acute care utilization. And this actually isn't a patient, this is my mom. That's how I got around HIPAA violation there. So this is also my mom. So we identify the barriers in that patient's care, and then we direct them to the resources that are available in Las Cruces to improve their quality of life and prevent that recurring 911 use, recurring trips to the hospital, and everything else. So a lot of people ask me, Paul, why is the fire department doing intensive case management? You're not a social worker. And I say, you're right, I'm not a social worker, I'm just a grumpy fireman. But what is the value that the fire department has in this type of environment? Well, we have been around for a very long time. And long before I ever came, and long before anybody else that works at the fire department ever came before me, the fire department established trust with the community hundreds of years ago with what it is that we do for the community. And that trust cannot be duplicated by any other healthcare stakeholder. And that allows us to go into the home, meet the individual where they're at, listen to their story. Many of them are already familiar with us because they've called 911 many times. We figure out exactly what it is that's going on. We figure out what barriers they have, what sort of ambivalence they have towards changing their situation, and what it is that they need. And then we work on solving and working on making things better for that person. So you all will be very familiar with this pathway, but I'm going to go through it anyway. So how healthcare gets accessed. So you have a patient, and the patient's name is Bob. And Bob has a sore on the bottom of his foot, so he makes his way to primary care. And the primary care provider says, Bob, I know you have diabetes. I'm really concerned on the sore of this foot, so I need you to go to a podiatrist. So I'm going to generate a referral for a podiatrist. And so then Bob gets a referral and he goes sees a podiatrist. And the podiatrist says, yeah, Bob, you got a really nasty sore down here. We're going to need to go inpatient wound care. So he writes orders, and Bob goes to inpatient wound care. He's in there for a while, maybe 20 days. He gets a little bit better. He gets discharged. And then he gets discharged with orders for wound care outpatient. And then home health comes in and also provides wound care. So there's wound care pretty much every day for this individual. And he stabilizes. And then he does okay until he has another need, and then the process repeats. The problem is, we all know that Bob either doesn't have a primary care practitioner, or he doesn't have transportation to go to his primary care practitioner, or he can't get seen within a reasonable amount of time. And then even if he did, he's not going to get to see the podiatrist for 3 months. And so none of this ever happens for Bob. And so what ends up happening is Bob's wound becomes septic, he becomes very ill, he becomes a member of the 911 system. We go, we stabilize him, we take him to the hospital. He's in the hospital, then he gets transferred to some rehab facility for his leg. Maybe he's in the ICU at $10,000 a day, maybe he's not. But that's all because of all of his other access issues. And that repeats over and over again for many patients. Many patients, just because they don't have what it is that they need to work this system the way that it was designed to be worked. So who are we seeing regularly that's calling 911 repeatedly? Who are we doing intensive case management with? Well, first and foremost, it's seniors. And those seniors almost always have a mobility issue in the home, and they want to age in place, and they're alert and oriented, and they can make their own decisions. And they don't want to go to some sort of an assisted living facility, but they're on Medicare. And if you're on Medicare, Medicare doesn't cover caregiver services in the home. And because caregiver services aren't covered in the home, then the option that they would have is they could do private pay caregiver services. Private pay caregiver services through an agency are between $22 and $24 an hour. Seniors are on fixed income. Most seniors can't afford that. Some do. Some pay $16,000 a month to have caregivers in their home so they can stay there. But most people can't afford to do that. And because they can't afford to do that, they rely on the only free caregiver service agency that exists, and that is the fire department. So we go over and we provide their activities of daily living and their caregiver services. The problem is that the fire department is a 911-based system. We can't stay there and bathe them. We can't make them dinner. We can't take them to the grocery store. We can't go pick up their prescriptions. And so those things don't happen, and those patients deteriorate. The second one underneath there actually calls more 911 more often than even the seniors do. and that is Medicaid patients over the age of 55. These people are on Medicaid. They do have caregivers, but they also have mobility, they have a mental health issue, and they have some sort of an addiction issue as well. And the combination of those three things creates a lot of ambivalence. And the way that Medicaid is designed is they will cover caregiver services in the home up to about 40 to 50 hours a week. And if you need more than that, then they say, well, we're going to transfer you to assisted living. But the problem is, in New Mexico, that's up to the patient. And because that's up to the patient, and they have a mental health challenge and they have a substance abuse issue, they're not going to agree to do it. And we will go 4, 5, 6 times during the day and the evening, whenever the caregiver isn't there, to meet these individuals' activities of daily living. And they are the highest utilizers of 911. And as long as they are alert and oriented, they can continue to do that at the expense of the 911 system. And the problem is, many of these people live in the low socioeconomic areas of Las Cruces where we have a lot of 911 use because we have a lot of patients that have poor health outcomes, we have a lot of crime, we have a lot of stuff going on in those districts, and now the people, the firefighters that we have on those apparatus are at this person's house instead of being available for that person. So it's a really big problem, and it's something that we see over and over and over again. So this graph kind of shows you 87% of my referrals are seniors that are at home, some sort of an unsafe situation, whether it's their mobility, the environment that they live in, hoarding, squalor, whatever it is. Seniors at home, unsafe situation, 87% of the time. Mobility is the primary issue with my clients 70% of the time. 66% of all of my clients have problems with transportation, so you can see that's a really big challenge for people. And then mental health and or some sort of an addiction component 34% of the time. So this is old data from the census, and we know how accurate censuses are, but it still points to something really interesting. So 14% of Las Cruces is seniors. If that's true, 29% of those are living alone, 8% have income of less than $10,000. I could get those people placed on the Medicaid waiver, they qualify financially, and I can get a caregiver in the home. It takes time, but it can be done. But 24% have income of less than $20,000, which means that 16% don't qualify financially for Medicaid. And if 16% of those people, 29% of them live at home alone, that means 660 seniors at any given time live at home alone in Las Cruces. They will never qualify for Medicaid, and this will impact the fire department for the reasons that I told you before. And then also 25% of Las Cruces seniors are veterans. And then probably you all have seen this slide. For the last 7 years, since 2011, 10,000 baby boomers have been turning age 65 each day. This will continue for the next 10 years. There is the potential for the healthcare system to absorb a whopping 62 million seniors by 2027. Is that sustainable? It's not. And Social Security is going to run out, and it's going to run out really quick. They say it's going to run out within the next 2 years. So that's all very worrisome. What are we going to do about it? I don't really know, but I think it's worth talking about. So let's transition to mental health. So 45.6 million people have a mental health disorder in the United States. Schizophrenic patients utilize 25% of all mental health dollars and 66% of all the mental health beds in the United States. You want to talk about low-hanging fruit? That's it. What do we do about these individuals? How do we fix this problem for them? The New Mexico Department of Health statistics are on the next slide. 4.7% of adults in New Mexico live with some sort of a mental health condition. Only 44% of adults with mental illness in New Mexico receive any form of treatment. The remaining 55% receive no treatment. And then people will say, well, Paul, there's a lot of people that live in areas where it's difficult to access. And I do agree with that. But New Mexico ranked 22 out of the 50 states for mental health access, and lack of access creates non-compliance. How can you be compliant with your medication if you can't go pick up your medication or you can't get a behavioral health appointment? And eventually, lack of access leads to 911 and emergency room usage. So let's talk about the crisis pathway through the 911 system of a behavioral patient. So patients present to the ER or this crisis triage center that we have via ambulance, police, or a walk-in. And the patient will then be transferred to some acute behavioral health facility. Now remember that private health insurance is really good at determining who is going to cost them a lot of healthcare dollars. So all of these patients are going to be on Medicare and Medicaid. Medicare and Medicaid covers an average 7 to 10 days in an acute behavioral health facility. After the 7 to 10 days, the patient is discharged back home or to the street if they're homeless with discharge instructions to pick up meds, to make it to an appointment and a behavioral health provider. The problem is they were there for 7 to 10 days, which isn't very long to stabilize a patient. They feel better. They don't have transportation. They don't have a phone. They're not going to be able to make an appointment. They're not going to be able to go pick up their medications. And so they will deteriorate over time. And the lack of access to obtain those, the patient ends up winding in crisis, and the process repeats over and over and over again. From 2020 to 2021, we followed 2 different clients who both had deep-rooted behavioral health challenges. One was homeless and had schizophrenia. The other had anxiety, depression, and a substance abuse disorder. They were both on Medicaid. Both were treated dozens of times in an acute behavioral health facility. Dozens of times, each of them. After each individual spent $1 million healthcare dollars, the MCO stopped covering behavioral health services. What could we have done with $2 million? How does this help either one of those individuals to do this pathway this way? Okay, let's move on to housing. So we frequently see patients that have various challenges that fall into common categories. So I talked about mobility before and mental health. Housing. Housing is becoming a really big problem in Las Cruces. That amount, the percentage of people that I see with housing challenges, whether they're facing eviction, they're homeless, or something like that, is increasing. And so is substance abuse. That is all on the rise. There are 550,000 homeless people in the United States. 25% of homeless people have a mental illness. 38% suffer from alcoholism. 26% suffer from some sort of addiction. There are 3,000 homeless people in New Mexico, and there are over 500 homeless people in Las Cruces. You don't realize that because you don't see them all the time. They're here, they're there, they're everywhere, but there are a lot of them. If this wasn't discouraging enough, those individuals are very hard to locate to provide services to. So I'll tell one of them, please, can you meet me here tomorrow at 3 o'clock? And then I'm at the mercy of whether or not they're going to be there tomorrow at 3 o'clock. The housing phenomenon. If you have a felony, you do not qualify for Section 8 HUD housing. If you are evicted from Section 8 housing, you do not qualify for 5 years. If you cannot pass a background check, you cannot rent through traditional methods. If you have a bad credit score, mortgage is out of the question. And then we all know how hard it is to obtain or renew your real ID. This guy doesn't even know where he was born. How are you going to find his birth certificate? You're not. It's really, really hard. And it's very discouraging. So this leaves... What does this leave for this individual? Well, some property managers will rent to problematic tenants, and then they can also potentially find some private individual that will rent a room to them who doesn't do background checks. And hopefully they're not problematic, but if they become problematic, they're going to be evicted. So these people move around a lot, and their living conditions are worse every time they move because their options diminish every time that they move, every time that they're evicted. So then that leaves motels. So how nice your living conditions are is based on how much you can pay at the motel that you're staying at. So a traditional or weekly hotel is anywhere from $1,000 to $4,000 a month. And I'm going to tell you, there are seniors that are living in motels with their Social Security check and their pension because they have mental health challenges, there's been some sort of a situation, they are not going to be able to rent through traditional measures, and so now they're living in a motel. And this is marginally sustainable for that individual as long as the hotel doesn't raise their rates. But these individuals do spend a lot on healthcare dollars because they have a lot of challenges. So then, if you can't do that, that relegates that individual to run down motels where crime, drugs, and prostitution is prevalent. And we did this. We did this by telling people that we're going to punish them for what happened in the past. If they've had a felony, we will not let them have housing. And so what we did is, because we're punishing them for something that happened in the past, it's hurting them, but it's also hurting us, because then we take all of these people and we put them into one spot, and then we wonder why we have shootings down on Picacho, why we have so much drugs, crime, prostitution. We did that. So it takes a lot of resources to do case management, especially any of you in here that are doing case management. It takes a lot of resources. You have to know who to call to figure out what it is that you're going to do. We've been doing this for 6 years. We've developed a lot of partnerships. I want to touch on a couple of those partnerships. The first is NMSU School of Social Work. So we have an MOU for second-year MSW students to deploy with MIH. And they're here today. So we have Alexa and Lindsay. They're my new social work interns, and they're going to be here for the entire school year. And this was approved for City Legal in fall semester of 2018. These are my two interns from last year. This is Charlene on the left and Jack on the right, and they're both out working and doing a great job, and we're certainly very proud of them. The other one I wanted to touch upon is Memorial Medical Center Family Medicine. They have a residency program of physicians, and the residency program feels very strongly that they should be out in the field seeing what's going on in the community, because there's a lot to glean from that rather than just being in a clinical setting all the time. So they do deploy with MIH as part of their clinical rotation, and we've been able to do a lot of good from having a physician at the right place at the right time with me to facilitate a good outcome. And it's a lot of physicians at any given time. And then I wanted to talk about Dial-A-Ride. So Dial-A-Ride is a transportation city-run entity through Roadrunner Transit that provides 300 rides to seniors every day to places like dialysis, their doctor's offices, and everything else. And it is free for seniors, but because they give so many rides, because we have so many seniors, there's a 20-day notice. So here's some discharge paperwork from Dr. O from Memorial for this guy, and they want this person to follow up with Dr. Rowland tomorrow. How is that guy going to do that? He's not. He's not. And so what's going to happen to him? I don't know. For disabled persons, it's $2, but the caveat is that you can do 24 to 48 hour notice, so that's useful. And now that I've shown you the picture of the Dial-A-Ride van, you'll see it everywhere, because they are everywhere, making sure that people are getting where it is that they need to go. So we have our own wheelchair van to make sure that we can give people a ride. If they're disabled, if they're in a wheelchair, we can still get them where it is that they need to go if they need to go to some sort of a doctor's appointment. If they miss their Dial-A-Ride and they need to go to dialysis, we can facilitate that good outcome with this van. So here's the 2020 data for what it is that we did last year. So since we started in 2017, we have received 892 referrals. Some of those are from the fire department, But I get referrals from a lot of different places. I get referrals from Adult Protective Services. I get referrals from home health agencies. I get referrals from neighbors. I get referrals from the hospital. I get referrals all over the place because we have a lot of people that slip through the cracks and we don't have good solutions for those people. So I get referrals for them because we have to figure out what we're going to do. The average amount of referrals I get is 41. The most referrals I ever got was in April of 2020. I got 80 referrals that month. We've been able to reduce 911 use for people that we've graduated from the program, and by graduate I mean if I was able to solve what their problem was, 86% reduction in 911 use for those individuals. We've graduated 120 people since we started. We graduated 20 people in 2020, and we went on 992 home visits in the home in 2020. And I think that's important because one of the things that we didn't do a very good job as a stakeholder in 2020 when COVID started was saying, we're going to go in the home because it's the right thing to do. That got relegated to the fire department and the ambulance and the police department. And so we were the ones that were going in the home to provide those services to those individuals. So let's talk about our OO program now. So our OO program, we address substance use through harm reduction, education, and connection to treatment. And Thomas and Allison's number is up there, but it's in a subsequent slide. So the opioid epidemic, we had 10 million people over the age of 12 misused opioids in the year 2018, and 130 people die each day from overdose. It's a really big deal, and it costs a lot. It costs $179 billion annually in costs associated with death, CPR, medical resuscitation measures, healthcare costs, loss of productivity, the criminal justice system, child and family welfare. It's a lot of money. Overdose deaths in New Mexico have increased, according to provisional accounts made by the CDC. By the end of October 2020, 743 overdose deaths were recorded. That's a 25% increase in a 12-month period. So the pandemic is increasing the amount of overdoses that we have because it's causing stress and unpleasantries for people, and they're seeking to have some sort of resolution for that. And if you can't get to your behavioral health provider, and the behavioral health provider is doing telemedicine, and you don't have a phone, and you don't have access to what it is that you need, of course, overdoses are going to go up. The Doña Ana death rate from overdose is 17 per 10,000 people, and fentanyl overdoses are on the rise. Most of the overdoses that we've gone on lately are all little blue pills, and they're all fentanyl, and they're coming in from Mexico, and I don't know where they came before they came into Mexico, but that's the situation that we have. And fentanyl is incredibly powerful, and I'm sure you all know that, so I won't touch on that too much. So we review all of the overdose 911 calls that we go on, all the CPR calls that we go on, and all the unconscious unknowns. And we look at every single one of those reports, and then we tease out whether or not it's really an opiate overdose or not. And then we take that number that we have, and we go out and we meet with those individuals and try to offer them Narcan education, resources. We refer or transport to services if desired. And then we work with community providers to streamline those services and enhance communication. And we have the ability to do needle exchange in the field because we believe that harm reduction is important as well. So in the month of July, we looked at 119 calls and we identified 32 overdoses and we contacted 14 patients. In August, we identified 156 calls, and then we whittled that down to 35 actual overdoses, and then we contacted 25. So it's actually increasing steadily. And if you look at this graph and ignore the fact that we haven't actually completed all of September yet, so this dip doesn't actually exist, and October 0, the actual number of overdoses is increasing over time. So we want to reduce and prevent overdose deaths. We want to refer these individuals to resources that are in the community. We want to provide prevention and treatment options because it leads to reductions in ancillary outcomes. And less crime, violence, poverty, and homelessness, and everything else. And so we think that that's very important. And we partner with medication-assisted treatment providers, behavioral and mental health providers, detox providers, and we believe it's important to share that information. We operate under a grant in this section, and obviously with grants you have to provide data, and we don't provide protected information, but the grant wants to know how many overdoses we have, and we think it's important to share information with the community, so we provide that overdose information to other behavioral health providers as well so that everybody can know what's going on in the community. And then Allison put a whole bunch of references in here, but I didn't do that on my side. So here is all of my contact information. So Thomas is the paramedic with the O program. This is the office line, but it actually forwards to the cell phone. Allison is our social worker in the O program. Here's their emails, and then there's my contact information. So I appreciate all of you being here today. Thank you very much. If you have any questions, I'm happy to answer any of those questions. If you don't want to answer the question now or you think of the question later, you can certainly reach out to me via email or the phone. So thank you all very much.